Hi guys, it's Dr. Gillard. As promised, here is a review for your midterm over differential diagnosis to the lumbar spine. So I don't know, I got my PowerPoint just in case we have time. I don't want to make this too long, but here we go. I would definitely know something about the following stuff. What's a typical, know that a typical disc herniation is paracentral, and know which nerve roots a paracentral disc herniation compresses. It always compresses the traversing nerve root, the one below. So in L3, typical disc herniation at L3 in the left will compress the L4 traversing nerve root. Also, make sure you know the innervation, what innervates the back of the disc, what innervates the anterior part of the thecal sac, what innervates the facets. I'll let you look those up. You should know those. And let's see, what else do we have here? Know the three parts of the intervertebral disc. Don't forget to include the vertebral end plates, right? And let's see, what else do we have? Make sure you know all about the difference between lumbarization and sacralization. Sacralization is a transformation of the fifth lumbar vertebrae typically into a sacrum, a sacrosegment. And lumbarization is a transformation of the S1 sacrosegment into a lumbar vertebrae. So know a little about that. Know about where the nerve roots bud off the thecal sac. Where do they bud off the thecal sac? Remember we talked about typically L1 through L3 bud off above the same level disc, so the L3 exiting nerve root buds off the back of the L3 vertebrae. But remember, it gets a little weird. The L5 or the S1 traversing nerve root buds off not behind the S1 segment, but it buds off behind the L5 segment. Therefore, it is exposed as it passes the L5 disc and is vulnerable to herniation. Make sure you know your basic anatomy, know the parts of the vertebral arch. Remember, they include the anterior part of the spinous process is part of the posterior arch. You know the other ones. Remember the zones, and this is pretty much week one I'm all going over now. Remember the zones of the spinal canal: central, lateral recess, neuroforamen, extraforaminal zone. Make sure you know those. Know the components of a good history. I'm going to hit you with those again. I would memorize that mnemonic of mine, or you can use yours, but I would use mine if I were you. Let's see, what else do we have? Know what forms the facet joint. Remember the 9 typical causes of low back pain. Make sure you know those because there's probably going to be a question on that. Definitely know the ligaments of the spine, anterior and posterior longitudinal ligaments. Remember, posterior longitudinal ligament actually helps make up and give a little extra reinforcement to the back of the disc. Make sure again you know where those disc herniations are. Will a far lateral disc herniation compress the exiting nerve root? Yes. Will it compress the transversing nerve root? No. What type of herniation compresses the traversing nerve root? Paracentral, the bread and butter paracentral disc herniation. Why is that a bread and butter? Why does it usually occur there? Remember, there's a weak spot there where the main posterior longitudinal ligament protects the back of the disc. And as you move a little lateral, there's a weak spot where the main ligament starts to thin out, and that's the paracentral zone. Know how pain, remember we talked about how pain is transmitted from the sinovertebral nerves of the disc, goes down the gray ramus communicantes, gets into the sympathetic ganglion, sympathetic chain ganglion. You either one of those of L2. I could say L2. No, you better say L2 on that one. And then it goes in there. That's the one of the new theories of pain. Just make sure you know that. Let's see. We talked about the subchondral bone is supplied by a certain nerve. So know that. Remember this, the subchondral bone, which is right above the vertebral end plate, can be a pain generator. You remember that? Let you look that up. Remember, make sure you know what a motion segment is. Know the components of the, remember the annulus fibrosus, there's an inner part and an outer part. Know what they do. Sharpie's fibers are related to the outer part. Make sure you know what's normal doses of acetaminophen, ibuprofen, naproxen. Make sure you know those maximum doses. Might be some questions on that. I would definitely know my mnemonic. Remember the one about the drag racer and the idle? High pros never idle. I would definitely know that. Remember that doesn't include the history exam. Remember that was a different mnemonic. But the for the whole ball of wax, the history and examination, high pros never idle. Definitely know the red flags. Right out of my notes. Know about Cauda-Equina syndrome. Know about lateral listhesis, when you should order, and what type of motion radiography should you order. Flexion extension study? No, a lateral bending study, weight bearing, to assess stability. We want to make sure that's not sliding or rotating. Know about symptomatic central stenosis. You should know about that. Remember shopping cart sign? They like to walk, they like to be in flexion, so the old people will push a shopping cart around in flexion. Stenosis, central stenosis is associated with neurogenic claudication. Remember what that is? Patient will walk a couple blocks and his legs will start hurting real bad. They'll get heavy. Then he sits down and bends forward, and he magically, the pain goes away and he's able to walk a little bit more. It's usually caused, well, other things can cause it, but hypertrophied ligamentum flavum are usually involved. I would know some basic stuff about dish versus ankylosing spondylitis. Know what a chance fracture is. We don't call it a lap belt fracture. I want you to call it a chance fracture. Remember, you hit the telephone pole. The patient in the back seat just has a lap belt on, flexes forward, that acts as a fulcrum point, and snaps the pedicles right in half. There's a couple cases on here. Know about blood thinners. Remember, we learned in class those are yellow flag warnings. So you need to be careful. Probably shouldn't do, Dr. Sousa was, I think, hinting you shouldn't do grade 5 manipulation on those patients. Although I did check the literature, I couldn't find a single paper, so I'm not sure where that came from. Let's see. There's some more about the. Oh, you better know about the orthopedic tests here. Know which ones are good for diagnosing a disc herniation if you can run only one. Remember, slump is a little bit better than straight leg raise according to the research. They're both good, but straight leg raise will probably be more amenable to a patient who's acute. In other words, it'll be more comfortable, so I would pick that one if the patient was really acute. Make sure you know where the sciatic nerve leaves the pelvis, for goodness sakes. Between what muscles? Piriformis and superior gemellus. Alright, that's the written. There's 35 questions. Multiple choice, A through E, pick the best answer. Everything is right out of these notes. Now, 36 through 50 are going to be off the slides. Again, every single slide came right from the notes. So I would know the slides. Let's see. I don't want to make this too long. Let's see if I can figure out how to go through this without if it's going to behave here. So I would know, for example, if I might say, what's this thing? What's the major diagnosis? Two things you have to remember. This is the left side. Remember, images are reversed. So this is a left contained disc herniation. I think disc herniation is good. We're going to talk more after midterm about more specifically about this. But I think if you say or just a disc protrusion or disc herniation, but I want you to tell me where it is. It's in the lateral recess here, or you can say it's a paracentral disc herniation would be perfect. It's not a far lateral disc herniation, or it's not a central disc herniation, or it's not an anterior disc herniation, which would be up here. This obviously is a T2 weighted MRI. If you're really shaky on these MRIs, I was told you guys already know this, so I went fast over this. But I have a feeling maybe you don't know this so well, but I have some good YouTube videos on how to read your MRI, so it might be worth going through those because there are a lot of MRI images on here. Okay, I mean, here's another example. This one's not on there, but it's a good example. So here's another herniation. See it right here? And here's the oblique or the parasagittal through the intervertebral frame, and you can see the herniation right there. There it is there. So this is a far lateral herniation, which is contacting the dorsal root ganglia right there, right over the top of my mouse. What's that orange thing? That's the cut line on an MRI. So a cut through the sagittal shows where you are here. So this is the L4 disc. This is a far lateral disc herniation, or you could call it an extraforaminal disc herniation. And remember this. Okay, so this is the domino effect in action. So we have a degenerative spondylolisthesis that occurred above the level of fusion. So you could just say domino effect. You can say a problem has occurred above the fusion if something comes like that. But it's common because once this is fused down here, this bone gets a tremendous workout. And you can even remember we talked about stress shielding here. You can see. On the test you'd be able to see a lot more, but there's an area of sclerosis there, so you can actually see the fracture. Okay, promise I'm not going to go past 20 minutes. So HIZ sign, indication of an annular tear. You can see it right there. There it is again. That white thing is a pocket of swelling and inflammation. This is discography, right? We talked about discography. There's the needles. They pressurize, they pump a contrast into the disc to see where it's torn. This green arrow is a what? That's a radial annular tear, or just an annular disc tear. This disc is shredded here. Remember what that is? I'll let you study that one yourself. So this is obviously a what? Spondylolisthesis. It's grade 2, even a grade 3. So make sure you call it a grade 2 or grade 3. I'll accept either answer, but make sure you call it a Spondylolisthesis. Okay, here we're a nice example of what? Moderate to severe central stenosis. One of my patients actually had pretty bad intermittent claudication. We talked a lot about that, so make sure you know about that. Now look at how thin this is. You guys can't miss this. So many of you guys miss this on the quiz. It's just it, I mean, you can't miss this. Look at the pencil how the cortex of the vertebral body, it looks like somebody drew a white pencil. When you see something like this, it's severe osteoporosis. And then the hint is these compression fracture right here. You got part of the superior end plate caved in here. So compression fracture. Yeah, there's a calcification of abdominal aorta. That's not the major diagnosis. If there was a big aneurysm, then that would be the major diagnosis. But osteoporosis, if that's on there, let's get it right. Remember the three joints, there's the three where the axial weight load is carried. There's your zones. Make sure you know your zones, right? Those are where the disc herniations occur. Stenosis, we saw that one already. Make sure you know these muscles too. There might be one on these, which muscle is which. Okay, let's see. See what else we can see here. Remember we added MD's right medical medication poorly because we want to know the progress. I added that one on there. Case of the week. Remember what that was? Arachnoiditis. It's an inflammation of the cauda equina. Can be oftentimes it's asymptomatic. Sometimes it can be related to horrible bowel and bladder problems, as well as leg pain and perineum pain. Remember we talked about this procedure? Got to look real close, but here we have a laminectomy. And there's the spinous process of L5, there's L4, L3, L2, spinous is almost taken away. So it's a L2, L3 laminectomy. Doesn't matter. It's really the right side. Remember, everything's reversed, but it's actually a wide hemilaminectomy procedure. What's this again? Severe central stenosis secondary to what's these black things? Ligamentum flavum thickening. Notice the facet joint hypertrophy. So it's again, make sure you know that nerve. Know those parts of the posterior arch. This drawing didn't show it, but the spinous process is also part of the posterior arch. Don't call this a wedge vertebrae. Wedges it doesn't mean traumatic. This is a pathological. This patient has osteoporosis. It's a pathological collapse. So these are compression fractures. Compression fractures. Okay, where's the SI joints? They're gone, right? You can see the calcification here. This is ankylosing spondylitis. Don't miss that, right? Scotty Dog's neck has disappeared. This is oblique. So that's a spondylolysis. We can't see any slip, so it's not a spondylolisthesis, it's a spondylolysis. Scotty Dog, know these 9 causes of pain. I'm going over this stuff pretty much here. I would know this drawing. Right, traversing nerve roots. Notice this is L5. Remember we talked about Mickey Mouse. There's his head. There's his ears. The ears are the traversing S1 nerve roots. Traversing S1 nerve roots. This is the left. This is the right. These are the S2 nerve roots here. I'm not going to ask you that. Facet joint is right here. Okay, what are these things? These are the exiting L5 nerve roots, or you could call them the dorsal root ganglia of L5. Disc herniation. Did we talk about that? That's a facet cyst. It comes right off the facet dish like a ganglion cyst. Have to drain it or surgically remove it. There's a bone spur causing stenosis. Don't worry about that. You know the wiring we talked about. Know that wiring. There's a basivertebral nerve. Remember, it innervates the subchondral bone in a condition we'll learn later called isolated disc reabsorption. It's trouble. It can be inflamed. You can actually block the hole back here. Basivertebral foramen can be blocked with lidocaine. Those are what? Neuroforamina, or IVFs as you guys know them. So what nerve root is that? Well, L3 vertebral body, L3 disc, L3 exiting nerve root. Easy, you guys got it. Remember we talked about how the inner annulus fibrosus wraps around into the end plate. The fibers actually morph into the end plate. So the end plate is part of this system here. Sharpie's fibers are on the outside. These fibers, it's the inner, they're avascular, the inner fibers of the annulus, made of proteoglycan and collagen, type 1 and type 2. And their job is to corral and hold the nucleus pulsus in place. It's a teen disc. Everybody better know what that is. It's the nucleus pulsus of the teen disc. Remember, the disc has a terrible, terrible, terrible blood supply. Everything gets into the disc by diffusion. I'm over my 20 minutes. The only part that's innervated with blood vessels and nerves is the outer 1/3. Make sure you know that. Don't forget proteoglycan Bob. Proteoglycans love water. They're like water sponges. That was 2. Oh my goodness. We can't go through more of these, can we? I think you guys got the idea though. Let's go super fast through this. You know what that is. Don't forget, that's a neoarthrosis, sacralization with a neoarthrosis. We talked about that. A new joint has been formed. Don't forget that. Neuroforamen, right? Neuroforamen is right there. This is extraforaminal out here. Schmorl's node, right? It's a herniation into the vertebral end plate and subchondral bone. That's spondylosis, or I think you guys call it, you can call it degenerative joint disease. This is just spondylosis. In other words, just arthritis of the spine. Okay, you guys know these. Better know these. Better know that. I would know that, right? We talked about Modic. We're going to talk more about it, but I went over that. It's Modic type 1. It's a severe type of end plate degeneration, more severe than most people. On the T2 weighted, see the cerebrospinal fluid here is white. T2 weighted shows up white. T1 weighted, it shows up dark. So this is type 1 modic change. You should know that. Okay. I would know that if I were you. Definitely know these red flags again. We hit them again. You should know a little bit about inspection, a little bit about antalgia. Definitely know minor sign. Know the hairy patch, hemangioma. Could mean a spina bifida is under there. Or sacralization or lumbarization as well. Calpheal lace spots associated with neurofibromatosis. Okay. Do you want me to go over week 4 too? Let's go over week 4. I don't want to hear any complaining if you guys don't do well in this test. Compression fracture again. Definitely know that. Right, we went over that. So that's the neuroforamina right there. That's foraminal stenosis. It's severe neuroforaminal stenosis there. Or you can call it lateral stenosis. There's central and lateral stenosis we'll talk more about. Remember that one? There's the lateral listhesis. Remember, that's not a fracture, right? Psoas line. Oh, looks like somebody's doing some vacuuming. Sorry about that. Remember, it's not safe, right, until you get those lateral bending studies. Retrolisthesis. Talked about that. There's our cross-dresser. Shopping cart sign. I didn't even put that in there, did I? Shopping cart sign. That's an actual real sign. We talked about this case. Blue dots, ligamentum flavum. That's central stenosis. Ligamentum flavum. Better not miss those if they're on there. Fractures. Dish. Remember, dish spares the SI joints. See, the SI joints are nice and happy here. Not a lap belt fracture. Chance fracture. I already said to know those, what they do. Know the red flags. Know the minor sign. Know the sciatic nerve. We talked about that. No range of motion. Do not know range of motions. I'm not going to ask you the range of motions. We talked about the orthopedic test. Okay, this is getting way too long now. Okay, I think you got a really good overview of what's going to be on there. So good luck, and we will see you on Thursday.